So troubleshooting urostomy management. It's a big talk in a small amount of time. I do some clinical work for coloplastostomy. These photos are mine. These are my learning objectives. I trashed them. I got these from Ryan. I thought they were nicer, so I kept them. But basically, this is a big talk, so we're just going to try to hit the high points, and I'm going to give you a great tip to take home. So urostomy management, you got to start off on the right foot. In our bladder cancer program, which I'm happy to say we're learning more and more about our large patient population, we now have a fairly comprehensive bladder cancer program, including ERAS, but we have pre-op optimization, which includes some work with the WOC nurse or wound ostomy continence nurse consultation preoperatively. We had postoperative care standardization, and we have resources available for those patients in dealing with urostomy challenges and complications, including myself and another nurse practitioner who are WOC nurses, so we're available both inpatient and outpatient to this patient population routinely. Not everyone has that privilege. So postoperative care standardization for us included postoperative visits with stents and drains being addressed, access to the WOC nurse or an NP, home care, and we have a program at UVA for our surgical service called interactive home monitoring, where patients actually have some equipment they're delivered at home, oxygen monitor, blood pressure, a cuff, and a scale. Preoperatively, they get an advocate, which is a nurse or nurse practitioner assigned to them, who's their access point every day after they go home from the hospital, stays in touch with them. They have an app on their phone where they load their data. Someone's watching that and calling them every day. That's their third person on the team, along with the surgeon and the nurse practitioner in the program. So that's been very successful. We're continuing to find ways that we can show that may be helping us prevent readmission. Let's talk about urostomy complications. There are stoma complications and peristomal skin complications. They can be different. So if you look at early post-op stages, we classically see issues with pouching and leakage. The goal is for patients to have reliable wear time. No leaks is the goal, ideally changing their pouch every 3 to 4 days, but sooner if a leak is imminent. And visits with a WOC nurse can be helpful in troubleshooting stoma issues, and long-term stoma issues could include stomal stenosis or bleeding, and I'll talk about those. So late stoma complications, while you may not be doing cystectomy in your practice, you may be seeing these patients in the community, you may be seeing them long-term. More and more patients are surviving bladder cancer. I have some 10, 12, and 18-year survivors of bladder cancer, which, as we know, bladder cancer is a very tough cancer. Not everyone is surviving at 18 years, but if they are, they're past the oncologic hurdles. Now you're really dealing with what we call plumbing issues, or thinking about structural problems that may happen as they live longer and as they have better successes. Even those with poor pathology at the time of surgery may live a long time now on the immunotherapy options we have for them long term. So you have to think about them getting past that 5 years of oncologic surveillance and what happens next. So, well, I think I would like to go back. Hold on, bear with me. Not that good with tech. So we recommend that patients be seen on an annual basis to be assessed. This is amazing. I was at a WOC meeting last year, asked for a show of hands in the room. How many people see patients after 5 years? Like 3 people raise their hand. It may be considered a burden in some ways. In our practice, we've decided it's worth it to have them be seen once a year with a renal ultrasound, just to get the chance to talk to a WOC nurse or to be assessed and to know that the upper tracts are being protected long after they've passed all the oncologic hurdles. Often stricture dilation is possible if they have stomal stenosis. I met a wonderful gentleman last year, 93 years old, a 20-year bladder cancer survivor, stopped seeing urology at year 10. He, taking care of himself, widowed, told the daughter one day, I don't think I'm making any urine, but I can't see my stoma very well. He basically completely stenosed off his stoma, but no one had assessed that stoma but him, and he could not see it well for more than 10 years. If we had met him 10 years earlier, we probably could have tried to at least dilate his stoma. Our reconstruction team was not very happy when I brought this guy to them. They were like, Terran, we do not want to touch this guy. And I was like, well, he's going to have to live with perks forever if you can't do anything. We were actually able to revise his stoma successfully, and I see him every 3 months to make sure he doesn't need dilation. His daughter said, it's worth it. I'll bring him every 3 months if we can keep him from never having that again. So you do have to think about what kinds of things could you prevent if you were seeing someone back in the office once a year. And peristomal hernia, very common, is sometimes tolerable, other times can require referral to general surgery. And prolapse, less common with urostomy, more common with bowel diversion. And mechanical complications, including ureteral enteric stenosis or stricture. So peristomal skin complications is really, I think, the bane of the existence for most people seeing patients out in the community. WOC nurses are available. They use location and distribution of that damage to figure out what the cause is, the color of the skin damage, the characteristics of the problem, again, focus towards what the solution might be, and finishing off with what information the patient reports. I want to tell you about this guide. It just got updated. I'm very proud of this brand new update. Anyone can have access to this. It's free. It's on the web. It is a newly updated peristomal skin assessment guide that is totally online. You can use it as an app on your phone. You can use it on the computer. Patients can use it. There's a consumer version. I'm going to skip this page because this is the QR code for it. You can do it right now. You can write it down and do it later. But you can scan this, and it's an algorithm that takes you through the right questions to lead to the right diagnosis for what is wrong with the peristomal skin. And it's validated. It works over and over again. You can have nurses who are not WOC nurses use this as a way to assess the patient's skin and the stoma problem, who may then refer to a WOC nurse if you don't have one in your area or in your clinic. It's an amazing tool. I highly recommend it. It's very easy to use, and it's an algorithm that every time you answer the question, it's going to lead you closer to what the problem is. So peristomal skin issues, everyone can recognize this is contact dermatitis. This is the difference. We see this problem in urostomies where the colorectal team may never see such problems, and that's the difference between bowel diversions and urinary diversions. Urine is tough on skin. So why? Usually poor pouch seal or leakage, incorrect barrier size, stoma construction. I had a patient the other day say, all my problems started last year when I saw my surgeon, my partner, back in the office. You weren't around, and I was having some issues, and the resident came in the room, and his advice was that I cut the hole bigger. I said to him, where did he get his WOC training? And he goes, I don't think that was a good idea because now I have all these problems we've been having for 6 months. And I was like, yeah, cutting the hole bigger was not the answer. I wish we had known about that. We could have prevented some of this. So remember, you want to think about how, if you use that PSAG or the assessment guide I just gave you, it helps you go right through it. Here's candidiasis. Remember, contiguous, not satellite lesions. Why? Moisture, compromised host, and medications. Chemotherapy patients, I usually advise our chemotherapy patients if they're actively getting chemotherapy to think about changing their pouch more often and to think about what chemical products they're putting on their skin because there's going to be some potential risk because of that urine and the metabolites. Dry environment, antifungal powder, that's nystatin powder. A patient came the other day and said, dermatology gave me this, it's called Greer's goo. It's a big thing of ointment. And I was like, how are we going to do that? He goes, I don't think my pouch is going to stick if I smear this on there, is it? I was like, absolutely not. Sorry you spent the money on that. Let's change that. Let's use some nystatin powder, which you can pouch right over. So thinking about, I don't like tape at all, but if you're going to use a tape, a porous tape, what is the cover on that pouch? How are you keeping the pouch dry? In the summer, I have patients who farm and patients who swim. We teach them to use a hairdryer to dry around their pouch and the skin around it to dry the bag when they get out so the pouch will not stay wet, and so the surrounding area may dry more easily. I had a patient who told me he was at the beach and they didn't have a hairdryer, but they had one of those hand dryers like a Dyson. So he was standing there with his pouch kind of under the dryer trying to get dried off in the men's room. All right, here's folliculitis, satellite lesions. Here's a retracted stoma, and I think you could probably see some mucocutaneous separation there at the junction. Here's a peristomal hernia. So here again is this peristomal skin assessment guide. Write it down. Have your nurses write it down. We can go on the site, write this down, put it on the bulletin board in the nurses' lounge. They can remember how to go there. Any nurse, any provider, any clinician, any urologist can use this to work right through skin issues. Thank you.